Bill, are you at home?
I am at home, yes. Looking out the window toward the blooming dogwood.
Oh, good, good.
Nice.
Okay, folks, I say we go for it here. I have confirmed that I'm recording, which I forgot to confirm last time. So we are recording. I will continue to let folks in as we get started. And we did send one last email reminder, so.
Bill, I knew you'd be on this call, so I wore this for you. I don't know if you can see this.
Well, oh, wonderful. Absolutely. Are they on sale afterward at a small price? Maybe a little discount?
Yeah, it's more university swag that we get,
Well, a really good man would make it available to his friends.
Yes.
Okay, officially, let's begin our third ever Zoom call for the Fort Wayne Medical Society. We are absolutely thrilled to have a wonderful friend of the organization, Dr. Mirro, leading today's discussion. And Dr. Mirro was president of the Medical Society in 1995. And in 2018, he received the Physician Exemplar Award, which is the highest award we give to any member. So he is of the highest regard with the Medical Society, and we are thrilled to have him here today leading today's discussion. So with that, Dr. Mirro, take it away.
Thank you, Joel. I think many of the members probably know some of my background. I'm a cardiac electrophysiologist, but years ago, coming to Fort Wayne, started a clinical research center. And as a result of that, we've really built an infrastructure to help Northeast Indiana respond to several things, research needs, and it became clear with the pandemic that there were certain needs that, because of this infrastructure, we're able to address. Number one was clinical research. We brought remdesivir to Northeast Indiana and have treated several patients successfully with that. Eli Lilly has a monoclonal antibody that also we've launched a study with. We are in an international registry for COVID and also participate in Mayo Clinic's expanded access using convalescent sera, and we're treating patients with that. Besides that, there's a simulation center, advanced simulation center and innovation center, which have been actively involved with new ventilator design and also PPE design. But I'm very proud of a team that we built over the last 5 years under the leadership of Dr. Tammy Toscos with health services informatics research. Because of that team, we have data scientists and human PhD scientists that are sorry, I didn't mute my phone. a team of 16 people that she leads. Dr. Toscos has a clinical background in dietetics. She was a dietitian, attended Indiana University, and did her dietetics residency in Chicago at the Hines VA. So she has a clinical background. She became very interested in electronic health records at that time. So she went back to school, got a master's in computer science from Purdue University, and worked for Intel out in Seattle on their mobile health strategy. She then returned and got a PhD in human computer interaction from Indiana University and did her postdoc at Regan Street, and has been very actively involved and continues to be involved at the statewide level on health information technology. Anyway, to make a long story short, I'm going to introduce Tammy, who was able to respond to the needs to create a community survey to figure out the impact of the pandemic on essentially different parts of our community. And it really came to light the importance of the social determinants of health, and that the parts of our community can be very adversely affected because of the different impacts, not just financial, but other impacts on the community. So with that being said, I'm going to introduce Tammy, who's here. Dr. Toscos.
Oh, you do that so well. I think I need to oh, it is being recorded. I can replay it later. Uh, well, thank you everyone for joining. As Dr. Mirro said, I lead a group of about 16 people who are very interdisciplinary in nature. We have research scientists, people who specialize in human-computer interaction design and really focus on user experience of health technologies, as well as data science, and we have project managers that keep us in line as well. We have a lot of partners in our work, including universities, different entities within our own health system. But one of the unique roles I think we play is partnering with our community. We've done a lot of work with churches, school systems, law enforcement, around topics like substance use disorder, youth mental health. And through all these interactions, we became acquainted with Dr. McMahon at the Allen County Department of Health. And so it was, I think I was flying out to Seattle on March 1st, and she emailed me and said, it looks like this COVID-19 is moving towards a pandemic, or the WHO was going to classify it as that. And she wanted to gather a bunch of stakeholders from Fort Wayne to see if businesses were ready to respond to this pandemic. So I was in Seattle, but I called upon my trusty team to help get a survey instrument together for that very large meeting. And I actually have a survey prepared for you guys today so we can interact using that exact same technology that we used that day. But during that meeting, which I think there were hundreds of people there, but you can see about 148 people responded to this particular question on the survey. It was held at the Coliseum. Maybe some of you were there. But of great concern at that time was that about 50% of businesses still didn't have a plan around mitigating the impact of COVID-19. And further, employers there identified that quite a few people that work for them were living paycheck to paycheck. So I think this, amongst other concerns, propelled Dr. McMahon to call upon us again to gather a group of stakeholders from across our community, people from philanthropic organizations, people from the city, people from healthcare organizations, and local businesses, to develop a survey instrument that would get a better gauge on how the community, where their needs were going to be within the community once this struck. So that was kind of the inception of the study design. And again, it was interdisciplinary. Initially was really gauged based on a standardized survey used by or created by the Department of Health and Human Services for businesses to be prepared for emergencies. We released the survey mid-March. It was up for just shy of 2 weeks. And this was a period from March 12th to the 24th when we weren't sheltering yet. So again, a very unique period of time. It had 19 questions. It only took about 3 minutes to complete. We had 97% completion rate, which is pretty outstanding if you've ever done survey studies. And we had a huge response of almost 5,000 people from our region. We did have some surveys from other parts of the country, ironically, but those were weeded out for analysis. Interestingly, also with this survey is we were really ahead of the curve in the country because of Dr. McMahon's initiative. And we have had both Cleveland Clinic and Columbia University in New York reached out to us and are using our survey questions because we had already published this at the end of March, and they still hadn't gotten a survey out in New York City. And so we have friends that work there, and they're using that data. So hopefully we can combine it at some point in the end. So in the survey, and please feel free to interrupt me any point in time. I'd love for this to be interactive. If you have any questions, just shout out. So one of the questions we asked in this initial survey were what are people's basic needs? And none of this is probably surprising that, and everybody expected this. In fact, a lot of people were like, why are you even surveying people? We know where the needs are. We know where the zip codes are that people are going to struggle. We know they're going to need food and medicine, and why are we doing this? And I think that while we did find some things expected, some things were unexpected in this survey. So we know that people need shelter, food, and medicine. Those are basic, but almost as important are contact with friends and family, access to medical care, non-surprise, but also cell phone use. So these are important needs that also need to be addressed, just with dealing with the social emotional aspects of the outbreak. So I would love for you guys to participate in this polling technology, which is what we used in that initial survey to answer this question. If you just want to shout it out, that's okay too. But if you have a mobile device or you're sitting at your laptop right now, you can go to this website, menti.com, just type in menti.com, and then you enter the code 346314. And this question will pop up and we can see your response to it. The entire group will be able to see in real time how everyone's responding. So I'll give everybody a little bit of time to see if anybody out there is interested in. I understand that many of you may be attending this and you're doing something else like grocery shopping or taking a walk or eating lunch. Those are all important things, so you may not have an opportunity to respond to this, but the question we're posing here is really, how has the pandemic affected your ability as a physician to care for your established patients who have chronic disease? Really like to hear from you about this, and if I don't get any responses, I'll just ask any of you that are on the line to share your experiences.
And as always, if we could just type our questions and comments in the chat, and I will relay them to Tammy. That way, we're not hearing audio from several different sources. And if we have a longer discussion, we can unmute for sure as the responses come in. So if you have specific comments, please enter them in the chat box, and I will relay them.
So as you guys are, it looks like we have a broad amount of disruption in care, and perhaps that's based on your care setting. Dr. Mirro, did you want to chime in at this point? Because when we were discussing this question, you thought there may be different care settings where there may be struggles.
No, thanks, Tammy. So I think we know that a lot of the physicians that are managing patients with chronic disease have successfully transitioned to a telehealth platform and been able to fill that gap. But some patients with pretty severe chronic disease, like heart failure would be an example, do need to be seen in the office, and they have fairly complex disease. Also, oncology patients are also a challenge of how to manage them, because they're also particularly prone to problems with coronavirus due to their immunosuppressed state. So those are two examples of where it probably disrupted their care. I do think one thing with the survey that Tammy's going to point out is that we thought, well, gosh, maybe we're getting a biased group of people that from a socioeconomic level are, pretty well off. So we don't know what's going to come out, because they obviously can take the survey and have access to the internet. But we found out, as you'll see, that they have pretty severe financial stresses is one of the big things, and access to food is a concern, and shelter, as well as access to medication. So.
Yes. Yeah. And I think, in the prior slide, we saw that connection with friends and family are really important. And I suspect that many of your patients feel that their connection with you as their provider is really important. You know, and that even through technology, that it just isn't quite the same as being in the office and being able to have hands-on with your patients. But so yes, as Dr. Mirro very nicely set me up for this slide, one of the, as I said, there were a lot of things that from this survey that we anticipated, but one of the things that was very concerning from our results was just the number of households who couldn't go beyond 2 weeks without a paycheck. And as Dr. Mirro said, we acknowledge that this is a biased sample we have, because we have people who have the ability to complete the survey online, and they are, you know, connected enough to know that it was even out there. We did push it slightly, but we got just a whole lot of responses just after Dr. McMahon had her first conference, public conference. So this was of great concern. And as I said, one of our most steady partners in developing this survey and using the results of this were the philanthropic organizations in the city, Meg Disler, the Catholic Charities, and Patty Hayes at AWS, and Marcia Toffett, the Lutheran Foundation, all, and the United Way, and I can't think of the new United Way CEO, but he also, they all came around with us interpreting this data and defining how they were going to work collaboratively to address this. The other partners we've had in this is the city. So they use this information to make a policy decision about evictions, so holding on evictions, and also holding on turning off any utilities due to a failure to pay based on this survey. So that as a scientist in public health, this was like really brilliant that as a community, this data was being used as a collective to do things for people. But as I said, this is a really biased finding. We know 93% of our respondents had health insurance, and a very small number relied on public transportation, which we used as a proxy for socioeconomic status. And then there were 4 zip codes that Meg Disler identified as ones that she thought would struggle. And we only had about 8% of respondents from those zip codes. So given that, we know that it's probably even worse than projected. But as Dr. Mirro alluded, there are a lot of working poor across our area. So these are the zip codes in our area where we saw had the highest percentage of respondents with who said they only had 1 to 2 weeks of financial stability should they not be paid with closures due to COVID. So the other, so we did our analysis then, because this was such a specific finding, we did our analysis clustering around those financial solvency groups. And we identified statistically significant differences between people who were either in that group 1 to 2 weeks of financial solvency compared to all the rest. And what we found is they have more chronic disease in the household, that they are more concerned with paying for prescription medications, accessing healthcare, and finding and purchasing food. So given that, again, really important guidance for our philanthropic organizations, but I think as care providers, that's important for you to understand as well, that your patients, even though they have a health insurance, they may really be living paycheck to paycheck and are really concerned about how are they going to pay for medication. So with that, if you guys want to go back to that menti.com, would like to hear from you what you think are the largest barriers you're seeing in providing care to your patient population during this pandemic. So I haven't used a question like this before. You guys are my guinea pigs. So I think you have to move around these statements and rank order them. So the options that Dr. Mirro and I provided for you to consider are lack of access to direct ambulatory office care, thinking that might be a concern for many patients. Lack of adequate technology to support virtual care, limitations in technology to provide meaningful virtual care, difficulty with patients obtaining diagnostic tests, and difficulty with patients obtaining medications. So even if you could just pick one of those, that would be your top concern, and type it in the comment area. It'd be really interesting for Dr. Mirro and I to hear what you're concerned about when with regard to your patients and their barrier. Ooh, look at that. That's cool. I love it. So difficulty with patients obtaining medications is popping out from the two people that took the survey. Thank you. Thank you very much for doing that. This might be a challenging question to fill out. Takes a little bit more time. So diagnostic tests, maybe obtaining the diagnostic tests because a lot of the testing centers had limited hours and so forth, I imagine. Very good. Well, obtaining medications, as it turns out, was a really big problem across our survey respondents. So with Dr. Mirro's help, we listed a few general categories of medications in our survey instrument, as well as allowed free text responses. So if you're looking at this chart, you can see that blood pressure medications and mental health medications were at the top for all of our respondents. That's across all financial categories. These were of top concern. I was personally surprised that diabetes medications were so low when compared to mental health, for example. And I'm a big advocate of mental health care. And I felt really embarrassed that I didn't even recognize that that was going to be a really important medication for people to be sure they could continue to get during this time period, especially with all the additional stressors of financial and social stressors. The word cloud down at the bottom right-hand side are the additional medications that were mentioned that people were concerned about. But when we looked at this a little deeper and we compared across those different classifications of financial solvency, you can see that for those less financially secure folks, mental health medications was the highest ranked concern. So to me, this was the key finding that we articulated. We've done this talk a lot, and this is the one that I always want to make sure that if you take anything away from what Dr. Mirro and I share today, that this is really critical for you to understand that a lot of your patients who have insurance, who have jobs, are very concerned about keeping up with their mental health medications during this time period if they were to lose their job. And we have not yet seen all the financial implications of this disease, and it very likely we will see another surge coming later this year. So these concerns are only going to become more profound. And as I said, these are the people who we have a biased sample here. So I really think that's an important thing to mention, and happy to discuss those findings. I don't know if the questions are coming in, or Dr. Mirro, if you want to weigh in on that a little bit.
I think that Tammy framed it very nicely, that mental health issues are substantial, and the lack of access to medications can play out overlapping their chronic disease, particularly if they're suffering from severe depression, for example. And this is a time where, with this anxiety and stress of the financial situation, and maybe they were furloughed from their job or lost their job during this time, it's a pretty daunting problem to deal with from a medical standpoint, to manage these patients in their chronic disease. So I think the clinicians' take-home message is, I don't think you can spend too much time with your patients finding out their stress and mental health issues and and also helping them get access to their medications, and specifically mental health related medications.
Blood pressure, that didn't surprise you either, Dr. Mirro, I'm sure.
No, that was not a surprise, but the diabetes was kind of a surprise. I thought that would be pretty high on the list.
Yeah, and again, we didn't include any questions about what diseases people had, so it could have been just based on the type of person that responds to, or the people that responded didn't represent a big cohort of people who had diabetes. So that might be one of the things we're seeing in the data. Well, and as Dr. Mirro just described, as people are getting furloughed from their jobs, or businesses are closing, we're going to have even different types of needs. So we once again went back to the drawing board with our community partners in the city and philanthropic organizations, businesses, and healthcare organizations to develop a second survey. We launched this about a week and a half ago. This time we have it translated in 3 languages as well, and really taking a grassroots approach to getting answers from the communities that we really want to hear if their basic needs are being met or not. So I ask all of you to promote your patients, friends, family members to complete this survey so that we're hearing from everybody, because there are all these organizations are going to be using this data to determine how to use limited resources from those organizations, the city and the philanthropic groups in particular. But this is a slide, no one's seen this data yet except for you guys. This is not finalized or clean data, but when I pulled this down, maybe it was Monday, we had about 636 responses to this survey. And this is kind of a busy slide, but the main point of this slide is that we see about a quarter of people still saying that their healthcare needs are not being met, and another additional 20% saying that most but not all their healthcare needs are being met. So we are seeing a need in the community still for healthcare needs being met. And a lot of the questions we're asking in, oh, sorry, I moved too fast. A lot of the questions we're asking in this new survey also relate to employment and how people are being able to access unemployment forms and so forth. So it's a much more specific survey this go around. So we've done about 5 or 6 different COVID related surveys, but I wanted to let you guys know that we did do a specific survey just for dentist offices, because they were concerned about whether they had enough, whether the offices in this area had the PPE they needed to get started back up again. And this is just one of the tables that we, one of the pieces of analyses that came out of that survey. We were able to get that survey up and running in 2 days and got the analysis done and back probably within a week and a half. Everything was done. And I just wanted to make sure that everybody in this organization knows that at the Mirro Center, that's how we operate. We do a lot of community work to support people in this crisis in particular. So if you have a need, and that's my next question actually, we know that you are going to continue to face issues as you go forward in the coming year. And we want to be there to help you, provide information to you to help you with your practice of medicine, because you're so clearly critical to our community. So this is a free text question if you want to open it up and answer it, or you can just type your concerns into the comment box on Zoom. And I welcome you to reach out to Dr. Mirro or myself, both of us, after this call or as you go forward in the coming months around the issues you see with COVID, because I'm sure much more will continue to unfold as we go forward in the coming year. So this is really my last slide. We have some backup slides. Our team has also been, we started working in the middle of March on modeling the surge using epidemiological models that were developed for other spread of disease. I will tell you that the models don't work very well. This disease is really different, but we do have some slides we can share around that. But at this point, I think I'll turn it over to Dr. Mirro to kind of wrap up our presentation. And Dr. Mirro, I can put on any of the slides that you want to talk to.
Thank you, Tammy. That was perfect. You could see how important this community survey is, particularly to target, as Tammy articulated, the limited resources the foundations have to target the greatest areas of greatest need and how to address those needs. So I think we'll continue to uncover where those needs are as we evolve through the COVID-19 experience, which is certainly far from over. Tammy, you might want to pull up the modeling slides, or one of them. We could talk a little bit about that.
These are the, yeah, I do want to point out that we do have a lot more detailed analysis from the first survey. If anybody's interested in that, we have an infographic that's posted on the Allen County Department of Public Health, or Allen County Department of Health website as well. But what do you want to talk about first, Dr. Mirro?
Well, might just show the one summary slide of your current work with. That's perfect. So as Tammy mentioned, almost all the modeling that's done, makes some foundational assumptions, right?
Let's go to this one. Yeah, this is a good one to talk to that. Yeah.
At the beginning, and all of you who are on the call that are clinicians know this is a very dynamic time, and so the assumptions at the front end are not static, particularly with regards to sheltering in home and also just human behavior. All of us have seen how compliant people are or not with wearing masks in public, et cetera. So I think the initial models seem to overestimate the peak. And so with the data science team that Tammy has, they've used really pretty sophisticated modeling, and these are the models that have been utilized. And in fact, she worked in concert with the Fairbanks School of Public Health at Indiana, as well as the state on this work, and actually evolved their thinking as far as the models. And I believe now the latest update on that is using a model that Los Alamos has put out. Is that right, Tammy?
Yes, yes. There, this diagram goes through sort of the different types of models. So you might have seen the IHME model that the president was using at all of his updates. That's a curve fitting model, and that also is the curve fitting model is what is used to predict the flu. The CDC has a model that predicts the flu based on a curve fitting algorithm. And that's what this Indiana was using at first as well. The limitations, there's benefits and there's pros and cons for every model. And the limitations of the curve fitting model, which you probably all saw if you were following it, is there, it's changing all the time. And it's changing all the time because, as Dr. Mirro said, the inputs are changing all the time. And this is a simulation, and your inputs are exactly what predicts your outputs. So knowing that wasn't sophisticated enough to account for how this disease is spread, because we know that it spreads amongst tight-knit groups in very dense populations, but it also spreads very easily in not dense populations. So it is a very interesting disease spread, and because of that, our team decided to use what's called an SIER model, which takes into effect the S stands for, at the beginning of any kind of pandemic, you have this whole bunch of people that are susceptible. Then you have later the infected folks. You have people who are exposed, and then you have a recovery period. So this model allows you to put in a lot more assumptions and more variability in that what we call the R naught, which is the actual rate of spread. So an R naught, for example, for the flu is, I think, 1.7, and the R naught for COVID has been reported to be anywhere from 1.7 to 5.5. So anywhere in between, and you can see that's why a lot of the models have had a hard time predicting and have over predicted a lot, because these initial data coming out of Wuhan showed very high R naughts, which just haven't played out, and that definitely hasn't played out in our community just yet. Yeah, as Dr. Mirro said, I think we did influence the state's thinking. They stood up an SEIR model right after we did, but again, there's no crystal ball with this, so it's a really challenging time to be a data scientist. It's very depressing because it just doesn't always pan out. But I see there's some questions here, and I just want to make sure I have a chance to read those.
Sure, I can. There's the newest one that came in is specifically on the SIER model. With the new SIER model, do you predict a large surge, and if so, when?
Oh, what a great question. I just moved the slide perfectly. So this is our Parkview model, and this is plotted against just Parkview admissions. So in our modeling, we made a lot of assumptions about how we used a 15 county catchment area in our calculations. We used a specific, R naughts, which you can see at the very bottom, 2 different R naughts. So the orange line is an R naught of spreading from 2.7 to 2.1, showing a peak in August 15th. And then for a lower R naught of 2.5 to 1.7, a peak occurring in September. And the thing about these models, however, is you have to realize the assumption that goes into these models is that everybody eventually is going to get COVID. So again, these things aren't perfect, but, and especially we're limited with the SEIR model because it doesn't allow us to model that second wave that we're gonna see. So right now, over the last 2.5 weeks, we've been developing an SEIR model, which will allow us to show that second surge. We have it running, but the outputs, we're still doing statistical validation on the outputs, but we will be sharing that, of course, once we get that up and running. But so you can see from our data that we were running along this sort of lower R naught, if you will, for a good period of time, but now we're dropping off. And that's the weakness in the model. You just can't look ahead very far. So another popular model that's out there you may have seen is the PenMed CHIME model. And that model is also, it's an SIR model. That's what it was originally. And now they have stopped predicting a surge and they're only looking 30 days ahead with their model. So that's just kind of how dynamic the situation has been. And I don't know if that answered the question or not.
This is actually very good, Tammy. So Tammy's team has shared this with the Indiana Hospital Association because you could see how critical this is in planning bed capacity, ventilator capacity,
right,
for the future. So to try to predict as precisely as possible the secondary surge will be really important. And so these models are, as all this shows is evolving, and the data science around this and the mathematics pretty sophisticated.
It's super, oh gosh, it's super complicated. This is all hand coded in our programming language. It's a very complex computational, and the actual computations take many, many hours to run. for this model. And that's why I think a lot of people are just kind of stepping away from doing the complex ones because of the value add. Now, we started doing this, like Dr. Mirro said, to predict whether we would have adequate beds and ventilators should we hit a peak. That's how we started out. And now I think we're moving, now that we're trending downward. Sorry, Dr. Mirro, did I interrupt you?
Oh,
Okay, I do that a lot. This is just showing you, this slide just shows you how the different models have been evolving over time, and these estimated peak dates have gone all over the place. So it's kind of all over the place. Yeah.
Bill Cast, how do you settle on an R naught when you have statistics, and they may be bad data, I don't know. Out of Logan Sports, you have a high number of cases, enough cases that you should be able to use it, but a very low death rate.
Right.
And then out of Marion County and the rest, a very high death rate.
Right.
And you wonder, how did that happen? Is there a different strain of virus? How can we explain the Logan Sport numbers in Cass County?
In Cass County, that I think that can be possibly explained from testing. So because we have a limited number of tests, the initial criteria in the state were that you had to be showing symptoms and hospitalized to be tested. So that means that you, of course, are seeing, oh, you test positive, you're sick and sometimes die. But now that we have these more tests and we have these target teams that go in to Cass County and the meat packing plant, and they test everybody, it kind of changes the it changes your understanding of the R naught. So R naughts are purely a guess right now because we don't have adequate testing. And on top of not having adequate testing, our testing is not good. So we have a lot of false positives, and that makes this kind of estimation even more difficult. So all of us data scientists need a lot of therapy for how hard this is. Does that make sense, Dr. Cass?
Yeah, well, so it says confirmed cases, 3,870 per 100,000. So there's 1,469 cases. So you're thinking that's bad data. It is not, I mean, that's a large number for a not very big town. And
for Logansport?
Cass County, yeah.
Oh, Cass County, yeah.
But you can't cheat on the deaths. I mean, everybody knows who's dead, and there's only 2.
Right. And
so
it could be that
really
that meat packing plant is pulling people from a lot of different counties. So depends on where those patients are hospitalized and or die. Also, that could be another confounding factor in that data.
Well, I want to get sick in Logansport. That's where I want to get sick.
Well, that's true. I don't know if that's the case, but a lot of those patients went up to the South Bend area and down into Marion County hospitals. And I believe that we have a lot of our Burmese population that work in that meat packing plant as well. So I was wondering if we would see a surge in cases here, but so far I haven't seen that happen here either. But I think the data is there's a lot of holes. You can poke holes in just about any data that you see. If you guys aren't aware of the Indiana State Department of Health, of course, has their dashboard with statistics, but Regenstrief also has a dashboard that has some statistics that you can drill down on the county level, which is really helpful. Parkview recently made the decision to share data with our state data warehouse. So now that it's possible to see our data reflected in context with the rest of the state, which I think is a really great movement forward. But yeah, I'm sorry, I can't answer your questions any better than that, Dr. Cass.
Yeah, I think Bill, Dr. Cass, that's a great question. But whether or not there's different forms of the virus that we're seeing is a question that really it would be interesting to answer as time goes on, to do an analysis of the actual viral do genetic analysis of actual viral infections for different regions to see if there's some geographic variation, right? So it's very interesting. But I think you could get a vacation home over in Cass County, Bill, and stay over there this summer.
Yeah, it's a wonderful place. I was born there. I was listening to This Week in Virology this morning, and they said that the single-strand RNA viruses all mutate, but that the flu mutation was on the contact protein phospholipid, and the mutation in SARS viruses was not. And they did not expect the vaccines to be as wildly different as they are in flu. I thought that was a very interesting comment, because This Week in Virology, those people are ordinarily very good. And they were just speculating on the difference between SARS and influenza.
That's interesting. This is yeah, and that would affect, if it's mutating, then that would affect reinfection as well. And I think there's a lot of talk about that. You know, are you really immune after you've had this or not? You know?
Yeah.
That's a question that's similar to a question that we have asked here, if I can just find it, about herd immunity. There's a lot of talk about everyone just getting COVID so we can develop herd immunity. I understand the need to protect the health system. What worries me is the assumption if one is healthy, they will get sick, recover, and develop immunity. How true is that?
Well, I think we don't know yet. But I think obviously the experiment that's going on in Sweden may be telling. That's the approach they're taking. They do have a very high, they have the highest death rate in Scandinavia in their elderly population. However, they are allowing, the younger folks to basically commingle, and they're keeping their bars open and restaurants in order to actually see if they can create herd immunity in their community, which will take about, when 70% of the community is infected, that's the kind of the threshold for herd immunity. So it's an interesting experiment, although it's at the cost of sacrificing some of the disadvantaged populations and elderly population. But I guess if you have socialized medicine, that there's probably a financial interest in that happening, I guess. But I hate to say that, but I think people have thought about that. It's hard to know. And again, as Tammy touched on, we don't know if you could get reinfected, and there may be different strains, as Dr. Cass pointed out. So those are all questions yet to be uncovered.
And another question, now that we are, a timely question, now that we are reopening, how much should we be testing?
Well, I think testing needs to be pervasive, particularly as you were going to see in the fall. The universities are going to try to open, and then, when you start testing asymptomatic people, you're going to have false positives, and so they're going to be quarantined. In all these questions. So when you start testing a lot of people, it raises a lot of questions, and I think the universities are all struggling with that. BioCrossroads, which is a large organization in Indianapolis, is trying to coordinate the universities, not just the large university, but there's even the smaller universities, on a strategy around testing asymptomatic people. I think from an epidemiologic standpoint, broad testing it will be important to get a better feel for, as Tammy articulated, that what's the actual prevalence of the virus in the general population, right? We do know that the serology testing, at least most of the things that are out there, are very inaccurate. And the FDA is actually going back, even looking at, and possibly going to pull approval on a number of the tests that they've already approved because of the lack of accuracy on sensitivity and specificity.
Okay, and Dr. William Pond has a comment. New data for Steuben from this weekend at Miller Poultry, 800 tested, 144 positive, 7 symptomatic.
Right.
That's great. That's exactly what one would think, that maybe we're just under testing the general population, right?
All right, I'm just scrolling down here. I don't want to miss anyone's question. Keep asking them if you have them.
I can talk briefly to this slide, which was updated using the ISDH data for each county on Monday. And there's lag in their data as well. So that is why that may be different than what Dr. Pond just posted. But I guess what we're trying to focus on now as a team, both to support Parkview and also our community, again, working with Dr. McMahon, is coming up with some type of for lack of a better word, calling it a COVID barometer, something that would help us track and kind of keep an eye out of what is happening around us, so that we can be prepared to, or we can give information to those who make decisions about social distancing and other policies in the workplace or in school systems. And so we're trying to pull in a variety of different data that might be kind of a proxy for infections and or social distancing or symptoms, to add to the data that we already have on from testing and hospitalizations. So this slide is one that we update regularly for Dr. Steinecker in our health system, who is trying to keep a pulse on what's happening in the surrounding counties. And one thing that came up yesterday in our statewide meeting was some of the numbers. You might see a push in numbers of positive tests that are associated with something completely innocuous. So in Marion County, for example, the Indiana University is conducting a study to look at the population, look at specific populations to try to see the incidence of asymptomatic people who are positive. And so they just have processed hundreds of tests. So it might look like there's a surge in Marion County, but it's really just related to the test, to that study. And so having those sort of qualifications on top of the data to explain the numbers is really important. You can't always just take these numbers at face value. So that's kind of what our team is working on right now with a whole lot of other people.
Yeah, so Tammy, to add to that, so as all of you may know, as the Indiana State Health Department is working in conjunction with Lilly on testing, and they want to enable and broaden the testing capacity statewide, so that businesses and educational institutions will have access to broad testing. And obviously, once you go down that path, how often are you going to test them? It's just because they're a negative, what is that? That's great, but maybe they need to be retested. Certainly, if they're symptomatic, they need to be tested. So I think there's a lot of questions about testing, but it does, from an epidemiologic standpoint, broad testing can be helpful in giving us a true analysis of the prevalence of the virus in our community, and to see how long it's going to be before we do reach herd immunity without a vaccine. This is a nice slide. Tammy, you want to explain it?
Yeah, this spaghetti slide. This slide was another slide we prepared back in March, started looking at other communities, metropolitan areas that were similar to Fort Wayne, to see how we were faring against other communities. So the reason these lines are all different lengths is because this is all justified for the first case on a timeline, and then looking at a number of days out after that first case. So you can see that Indianapolis had a surge, had that exponential growth, where Fort Wayne is a green line that's buried in the middle, did not. Madison, Wisconsin didn't see that surge either. So how do we explain these differences to Dr. Pond's point? Why are we seeing, you know, people die in Marion County, but not in Cass County? Those are very good questions, and I don't think we'll understand the answers to this until the end of all of this. And we do a lot of retrospective analysis on patients, people that got sick and recovered, and those who did not. And it's going to be a mystery for some great period of time. But this just shows, we were looking at how we were doing after social distancing and sheltering were put into place with this slide. So we felt like we were kind of in the middle of the road of like counties. And now we're looking at counties in Georgia that have, they were earlier to release the social distancing restrictions, and seeing how they're doing. So we might be able to react quicker, learning from their experiences.
I missed the question. I think the very first question that was asked, I missed. How is COVID definitively diagnosed? Seems a bit unclear with the talk of false positive, false negative.
Yeah, that's a great question. I think there are a lot of, Dr. Mirro probably should answer that one, but I think in the beginning,
I think that's a good point. I think it's definitively diagnosed by not just relying on the test alone, but the clinical presentation, right? So the presentation, the clinical symptoms that preceded or followed the testing. So that's one of the challenges with testing asymptomatic populations. You really don't know if they have it. And so now you potentially could be quarantining people that don't have it. You know, if you do test them and they're positive and you're asymptomatic, maybe they need to be retested by another vendor, right? Another testing vendor. So those are all really important questions, because the sensitivity specificity is different depending on the vendor. And actually, as many people know, every place is using this nasopharyngeal swabbing, which, by the way, the test is very accurate, except that the harvesting the sample is where all the discrepancies are coming in, false negative tests, right? There's not enough viral particles in the sample to adequately test. So there is a professor at Rutgers that invented a way to do this with saliva, which is his test is highly sensitive and specific, and actually Lilly is looking at his methodology to see if they can adopt that, because that's easy to gain samples from people. The sampling basically is like 23andMe or Ancestry.com. So I don't know if that answers, guys, but it is a diagnosis that you have to rely on both the clinical situation as well as the testing. So testing alone doesn't make in my mind, doesn't make that diagnosis.
And, you know, something we were dealing with earlier today was we're getting reports from a trusted source that employers are requiring negative COVID tests to return to work, and even for asymptomatic folks. And just wondered if we had any thoughts on that as we work to message and deal with that here at the society.
Well, we've actually heard that there are, you know, employees that are very concerned about returning to work, and so the employers need to open up, and they want to rely on testing to verify that they have a safe workplace, right? However, all of us know in medicine that tests have limitations, and there are definitely false negatives. So it's I think you still have to monitor symptoms in an asymptomatic population, and vice versa. You could be excluding people from work that had false positives, right? So I mean, you have to accept that both of those things are risk going down that strategy.
Along with other agencies in Fort Wayne have created a series for businesses called Business Connect. And we can send out that link as well. So that's a seminar series, you know, tailored to different industries on the concerns around reopening and how to reopen safely. and that might be a good resource.
Yep, thanks for mentioning that, Tammy. That resource was also in conjunction with the Greater Fort Wayne, Business Council, as well as the Northeast Indiana Regional Partnership. So the business committee was very involved with putting together these webinars, and it's to try to discuss these situations with testing asymptomatic people in the business community, to try to inform them of the limitations of testing, and that's part of it. And also to have, certain businesses that you cannot socially distance, and that's one of the problems with the meat packing plants, and the they basically cannot socially distance, and so if somebody's infected, it's really a challenge. And those also are employees that are at the lower end of the socioeconomic scale, and so they're going home. I mean, and probably cohabitating with a lot of their family, and that it could spread quite a bit. Cass County, as we've talked about, is an example, because I think 80 employees in that meatpacking plant are from Allen County.
Okay, Dr. Mirro, I feel I should say that the time is 1:01 currently.
I have to jump off, but I think, Tammy, can you carry on?
Yes, I think we're probably at the end of our time anyway, but I'm happy to entertain questions on or offline. I'll pass it over to you, Joel, to wind things down.
All right. We had one question. Just wanted to make sure that I read it correctly, as my background is not medical. What type of IgG serologic testing is Indiana trying to get? Is there any serologic testing IgG that has high sensitivity and specificity? Pardon me. What is the timeline for obtaining high sensitivity test? What do we think will happen when universities open in the fall?
So I can tell you,
sorry,
Eli Lilly's working on that. So most of the serology tests that are out there both test IgG and IgM, by the way. They're not quantitative, they're qualitative tests, not quantitative. You need to have a quantitative serologic test to know, to get some better feel for what level of positivity will be associated with immunity. So I think right now, the use of serology is really not recommended right now, because it's just hard to know how to interpret that, right? So, and also the testing itself, these tests are wildly inaccurate, at least of the ones that have been looked at, the 15 or so that are out there approved by the FDA, I think 12 of them are just horribly inaccurate. So I would advise not to do that until we have more science behind what we're doing with the testing. And the FDA is looking at that. I know Lilly's working on a more precise serology testing to answer the question, I think. And it would probably test IgM, IgG, and IgA.
Okay, and then we just have an update with some very relevant and important organizations getting together to put out a public statement from the local medical community, saying that as to why testing for returning to work should not be required, along with several other questions along the same line. That should be out mid next week, so that'll certainly be helpful.
That's great.
Okay, final questions here as we wrap up. Boy, this was so very helpful, and the technology with the interactive slides, which I first witnessed at the Coliseum meeting. Boy, technology really has taken some impressive leaps here in the last few years. So that is neat stuff.
It's a lot of fun.
Okay, seeing no questions, we will close out this meeting. I can't thank our guests enough. I already have next Friday's meeting planned. We're going to take just a little detour away. We're going to take a COVID break for 1 week, which is much needed. And we're going to talk with some ISMA folks about important state laws that are upcoming and they are working on. So we hope that the folks will join us for that. So again, thanks for attending today. We'll keep doing these as long as you find them informative. And I have to tell you, this is our third one now, and we have just covered a wide variety of important information on the pandemic. So thanks to everyone for joining us, and we hope to see you next Friday. I'm going to end the meeting now. Take care.
Everyone.